Hello, everyone. This is Nairi from Low Carbon Fasting. We have Dr. Ruth Tapsell with us today. Dr. Ruth Tapsell is a GP from Devon in the UK, southwest of England. Dr. Tapsell is a promoter of the low carbohydrate lifestyle, and she's actively involved in training other medical professionals and introducing them to the low carbohydrate lifestyle. Dr. Tapsell, welcome to Low Carbon Fasting.
Thank you for having me.
Dr. Tapsell, let's tell us more about your professional background.
So I'm a GP, so I see people with undifferentiated problems in primary care. But before I was GP, I used to work in hospital medicine for a few years. And part of that was actually in diabetic clinics. So I have got a bit of a background interest in diabetes. So I did all the exams and stuff that go with training to be a physician in the UK. But I decided for various reasons that I wanted to be a GP and sort of family medicine and that kind of thing. So so I've always been interested in sort of holistic stuff and lifestyle stuff, but it's only, I suppose, in the last few years where I've really got my teeth stuck into the lifestyle side of medicine, because I've found an approach that works quite well now.
That's amazing. Have you worked in Australia as well for a couple of years, or did you study there?
No, so I wasn't working. So I was just sort of producing babies in Australia. My husband was working, and I was on maternity leave. So yeah, no, I didn't do any work out there.
That's amazing. Okay, so how did you get introduced to the low carbohydrate lifestyle?
So it was my husband, actually. So Sam and I worked together, and he'd come across David Unwin in one of the GP sort of journals. I think it was Pulse Journal. And he was reading about how this GP up in the north of England was getting some incredible results with his patients with type 2 diabetes and getting remission after remission. And he was like, you know what, we need to actually look into this and think about doing this. And so, we're quite cautious practitioners, but we decided that we were going to have a really good sort of dive into it. And it just made so much sense. And I suppose we're a little bit ashamed that we hadn't sort of pushed for that sooner. I've always been aware of carbs, because we know about, when you put people on insulin, you always to teach them about carb counting, don't you? And I've always been, an advocate of slow release carbohydrates. So I was always aware of it, but it was only when we came across David Unwin's work that we realized that actually even the brown carbs, the brown pasta, the brown rice, the brown bread, they will also, cause problems to people who struggle to deal with blood glucose. So it was about 3 years ago now, I suppose. Yeah. So we started trying it out, and it seemed to, work for almost everybody. You obviously get the odd exception who doesn't want to follow that diet or would rather take the tablets, but I'd say virtually everybody that tries it really works for, which is a complete contrast to the previous advice that we used to give. So, and also the fat thing is really interesting, isn't it? So we've stopped saying eat low fat. And I think that's so key, because I think if people are restricting their fat intake and obviously their protein intake, then they're just hungry all the time and thinking about food and thinking about snacking and can't pass the McDonald's without popping in, that kind of thing. So it just seems to suit most people so well, this approach.
Yes, and I think it's quite natural if you are cutting or eliminating your fats, or reducing your fats and protein, then you are going to eat carbs. What else is there to eat, right? I mean, you have to eat. So that's what I used to do as a type 1 diabetic, because the advice was eat grains and whole grains and match your insulin. I think you mentioned about, the diabetics carb counting. Carb counting was a good skill. I mean, I'm very grateful. I attended several courses and count carb counting, but that didn't help me. That didn't improve my health. I was able to count the carbs, but matching the right amount of insulin to the carbs was a nightmare. That's almost impossible, as we now know. I didn't know back then, but we now know from Dr. Bernstein's work, you cannot 100% match insulin to carbs.
Absolutely. And then you end up with overshooting and undershooting and insulin stacking and all those things. So it's a no-brainer, isn't it? Why are type 1s told to eat lots of carbs? It doesn't make much sense, does it? So But actually, you know, I was, you know, it was all about type 2 when we started out. But actually, the more you sort of dig into it, I suppose I've been like pulling on a thread, and the more I pulled, the more I learned, and the more I was fascinated. And then, you know, I hadn't really considered people with type 1 because we don't have that many patients with type 1. And those that we do have, we just don't really get involved with their care very much because they're very much looked after in the hospital settings. But it just, you know, when I came across, you know, Dr. Bernstein and then Ian Lake, of course, I was just absolutely sort of bowled over by the fact that, you know, why are we not using this approach in people with type 1 as well? Because it makes even more sense for them because of the, you know, the law of small numbers. It makes so much more sense.
Exactly. Law of small numbers and small errors. I mean, you are going to make errors. This isn't perfect, but the errors will be marginally small. So,
absolutely.
So you don't treat type 1s at your clinic as a GP, do you?
Well, we've got patients with type 1 because it's a general practice. So, you know, they're all registered with GPs somewhere. So we do have them on our books. So I do see them from time to time. And I have tried to help several of them. But it's really difficult because they get a completely different message when they go to the hospital clinic. And so, you know, I've actually lent them my Dr. Bernstein solution and my Dr. David Cavan's type 1 book as well in the hope that they'll sort of get the idea. But obviously, you have to be really clear on saying, look, if you do decide to do this, you've got to very carefully sort of adjust your insulin and offer to support them with, you know, with ways of doing that. But yeah, I'd love to say I've had lots of success with my patients with type 1, but it's still an aspiration rather than a reality for me, unfortunately.
But we are a minority. I mean, type 1s are a minority. And I have to add here, I haven't had support from the diabetes clinic at my local hospital either. I haven't had the support. If anything, I had a bit of dismissiveness, and that's why I stopped sharing my success stories with them and telling them the details of what I'm doing. All they would see was a reduced HbA1c, and they would praise me for it, and I would say nothing, because when I did speak about low carbohydrate diet, in fact, my consultant at the time said, "Oh, if you're ever considering having a baby, you must eat carbs." Yeah. And of course, I came home and I researched, and there was absolutely no truth in that. I found quite the opposite to be true. And I found that in the United States, fertility clinics are opening based on, you know, treating insulin resistance with low carbohydrate lifestyle. So,
it's so sad, and I'm sure they'll come around eventually, but they're being a little bit slow, aren't they? And I guess one of the reasons for that might be that the doctors and the nurses who are in the hospital setting, they're not seeing their patients as often as we are in primary care. So we're able to, you know, if we're feeling particularly, you know, nervous about a patient, then we'll we can get them back every week if we want to. Obviously, that will depend on how much time we've got. But I think in the secondary care setting, you might only see your patient once or twice a year. And also you don't see those success stories coming through like we see. You know, some weeks I have 2 or 3 success stories. And so that just sort of keeps me going and going, no, this does work. And so that's why we're you know, sort of really keen to keep going with it. Whereas if I was working in a hospital setting, I might only see 1 success story, like you, very occasionally. And so it might not really sort of click into place. You might just be considered to be an outlier.
That's right. So I mean, I did talk about, I mean, one myth about we need carbs to be able to sort of conceive well. That was definitely a myth. So there are a lot of other myths ingrained in people, and one of them being the low fat. I mean, if you know, don't eat fat, so you don't become fat. Or how do you explain the truth or the science to your patients when it comes to fat intake?
So I guess I talk about the insulin model. So if you're eating lots of carbs, then you end up with assuming you're not type 1, obviously, you end up producing a lot of insulin to combat that rise in your blood sugar. And it's that insulin which is a fat storage hormone, and its job is to, you know, push the sugar levels down by, you know, pushing them into the cells, and any excess, you know, ends up in the liver, and then the fat cells grow, and then you end up with insulin resistance. So So yeah, you have to match the explanation to the patient and the level that they want to go to, because some don't want a sort of a, you know, I remember having a conversation with one lady about insulin and she was like, whoa, you lost me. You know, she did not want to know. But other patients can't get enough of it and are really, really keen to, you know, to really understand the background behind it. But yeah, I'm not sure I found the perfect explanation for it, but that's why I keep listening to podcasts and, you know, following people who are, you know, people like Ben Bickman, who's obviously really good at explaining all this stuff. You just keep learning, don't you? But yeah, it's a really difficult one to try and persuade patients when they've been, you know, brought up on this idea, you know, because we all have, haven't we, ever since the 1970s or whatever, that actually if you eat fat, you will get fat. It's so difficult trying to undo that and say, actually, it's not about the fat, it's about the sugar and the carbs, particularly obviously the processed food now, isn't it, as well? That's really, really important.
That's right. I mean, another myth, of course, is the protein. So don't go on a ketogenic diet because it's bad. It will damage your kidneys because you're eating excessive protein. I mean, not everyone ends up eating excessive protein, but even people who do end up eating higher protein aren't developing kidney disease. So how do you explain this to your patients?
Well, we're really lucky that David Unwin has done so much. You know, he's been so careful at collecting his data, hasn't he, over the last 8 years? And I suppose he's had to, because he was a real sort of trailblazer. So, and he's a very cautious practitioner as well, isn't he? So he wanted to just make sure he wasn't doing any harm to his patients. And lo and behold, he's got data on all of that. So even though his patients are eating more protein, he's definitely not seeing any decline in their kidney function, which is very reassuring. And we had a fantastic renal professor. I don't know if you know Professor Marcus Seaman, who practices in Austria. He's a really interesting guy, actually. Now he has type 1 diabetes himself. So he has a really interesting perspective. So we had him on one of these webinars that I've been running, and he was a fascinating guy. So he's actually managing to really help his patients who've mainly type 2s, you know, who have got renal impairment. He's actually seeing improvements in their renal function in spite of their increased protein intake. So yeah, it's very reassuring, you know, what we're seeing, isn't it?
That's amazing.
And I suppose that's what I say to patients. If they are concerned, then I do sort of reassure them that actually, as long as they don't go overboard, I'm not sure I'd be encouraging them to eat steak 3 times a day. You know, I'm not sure what I'm basing that on, but I think intuitively, I think if people adjust their macros to the point where they're eating less carbs, but a little bit more protein, a little bit more fat, then actually I don't think they're going to a level that's going to be damaging.
Although some people are seeing great benefits eating steak, I'm not sure they're eating steak, but eating meat-based meals 3 times a day or even 2 times a day. So people are seeing benefits. I don't do that. My husband does. He's seeing improvement in his joint pains and chest pains and everything. So
yeah, absolutely. And it may well work really well for some people. I think I would worry more about people who are eating lots of carbs 3 times a day, because actually the effect that the rising and falling blood sugar and the insulin spikes that go with that, I think those are going to be far more damaging, you know, to the blood vessels that supply the kidneys and the brain and the eyes and all that. So yeah, I'm definitely more worried about the carbs than I am the protein.
I've always noticed that people are generally, and this is a global phenomenon, I think, but people are generally oblivious to the amount of sugar they're eating. Because I think in people's minds, sugar is the white stuff that they put in their tea. But other than that, they say, but I don't eat much sugar. I don't eat cakes every day. Then you look at the diet and it's like huge amounts of pasta and rice. We don't understand carbs, do we, as general population?
Yeah, absolutely. And so David Unwin's got these fantastic sugar infographics, and I use those all the time. And Catherine Castle, who's a practice nurse in Yeovil, she actually brought them to life by you know, she'd plate up some food and she'd put these sugar cubes below them and take a photograph. And I actually used those, and I did a talk for some patients the other night, and even though it was a Zoom-based talk, and you could sort of hear the pennies dropping in the Zoom room as people realised that actually, you know, pasta and rice and potatoes and, you know, even porridge can really be, you know, can spike your blood sugars really significantly. But yeah, it's a shame that this is all new to people. I mean, this is something that we should be learning about in school, because this is so important in terms of our long-term health, isn't it?
I agree, but we do learn about fat.
Yes.
We learn about avoiding butter and eggs, but we don't learn about carbohydrates at all.
I know. And the eggs thing drives me mad. I mean, that's so sad, isn't it? Because I grew up on this idea that you're only allowed 3 eggs a week, because any more than that would be too much cholesterol. And actually, I saw the other day, and I haven't really dug into it to see, what's the scientific sort of stuff behind it. But apparently, the more eggs you eat, the less likely you are to get dementia. So, and I'm sure there's lots of good reasons for that, because eggs are superfoods, aren't they? They're absolutely packed full of some really important nutrients. So yeah, such a shame that that we've been told not to eat eggs.
They're my favorite, and I haven't developed any kidney disease or anything. I mean, I was vegetarian for years, 30 years of being vegetarian with intermittent years of veganism in there. But just having 6 eggs in one sitting, and they're easy to eat. They really are easy to, and they're not too heavy, too rich in protein. 6 grams of protein in an egg, so they are easy to eat. I've eaten tons of eggs before starting to introduce meat, which I did now recently. So after 30 years of being vegetarian, so I've now introduced meat into my diet. So let's talk about meat. Obviously, I mean, it is possible to do the low carbohydrates, to adopt the low carbohydrate diet on a vegan lifestyle. It's not impossible, but it's a lot more challenging. Do you have any vegan patients or people considering becoming vegan to improve their health? Because I think that's something else that people want to do. People care about their health. They don't know what to do, and they're completely lost. So they go, oh, this is the most recent trend, so maybe I should cut out meat.
Yeah, that's right. And I remember we had some friends around for New Year's Eve a few years ago, before I was really into this, and they were all talking about how it was New Year's Eve and they were all going to go into the new year with some great resolutions, so they were going to embrace the veganuary. And I was there going, okay, yeah, sounds good. And it didn't occur to me that might make it difficult for them to actually be well nourished. And I myself was vegetarian for 7 or 8 years when I was younger, and I look back now and I think, gosh, I think I was probably quite malnourished at the time.
Yeah.
But yeah, no, I think you're right. It's possible to do, sort of a plant-based diet in a healthy way, but I think it's definitely more of a challenge. And I've seen lots of my patients who are plant-based who I worry about, because they're coming in with symptoms of, fatigue, and their blood markers aren't great. And even slim people, they might have a raised blood sugar or raised blood pressure, and they might be struggling with their weight or not. And you ask them about the diet, and they say, oh no, I've got a really healthy diet. And then you dig into it and you find that actually they have very little protein and very little fat in their diet. And I had one lady who was plant-based who was trying to get pregnant and wasn't feeling great, and she was known to be insulin resistant. She'd been told that before. So that was a really difficult thing to try and say to her, do you think you might benefit from introducing a little bit of eggs or fish even? There's no way I was going to persuade this lady to eat red meat. But yeah, sometimes patients are all ears. If they believe you do a good job of persuading them that actually protein and fat are important in their diet, and it's been difficult for them to source those things through a plant-based diet, then some people will really go for that, but other people, they will be like absolutely flatly not interested. As far as they're concerned, for environmental or ethical reasons, they've decided that the plant-based approach is the one for them. And not always with good health outcomes. Yeah, so that's it's a bit of a challenge, I think, because the vegan movement is a really powerful one, isn't it? They've done a very good job of persuading people that that's good for their health and the environment. I would say if you have a really highly processed diet and decide that you want to improve on that by going plant-based, I think if you switch to a plant-based whole food approach, I'd say that's definitely a big improvement on the average UK or American diet.
Yes.
I do. Yeah, you've got to eat a lot of nuts, I think, to make up for your your protein and your fat.
But then with the nuts, of course, you're getting the carbs as well. So it was very
true. Yeah. Yeah.
I was at my unhealthiest. Of course, that doesn't apply to all type 1 diabetics or all vegans. But for me personally, I was at my unhealthiest when I was vegan and didn't eat dairy, and I didn't eat eggs either. So
yeah. And were you quite careful about how you sort of formulated your vegan diet?
I wasn't doing low carb at the time. So all I ended up eating was tons of pasta, and I'd still be hungry. And I would carb count. I'd go, okay, that's 90 grams of carbs just, from the pasta. And I'd still be hungry.
Yeah, absolutely.
I was never full. Of course, I wasn't eating protein. So carbs only sort of fill you up for an hour, and then I was constantly eating. I would eat constantly, and fruit and yogurt, and I was constantly hungry. And yet, strangely enough, I was underweight.
Were you? That's interesting. Yeah.
I was underweight as a vegan. Well, interesting. And my blood sugars, of course, were at their highest peak when I was vegan. So, but some people are doing it successfully. So
that's right. It's possible, but I think it's a challenge. You've got to really be very careful, haven't you? And definitely avoid the fake meats. I think that's a mistake. I definitely don't think people should go down that route. I'm sure that's not good for the environment as well. So
no. And that's processed food, so we don't want to eat processed food. So
yeah, absolutely.
Is cholesterol an issue for people who eat low carbohydrate sort of meals with higher fat intake and higher protein intake? What do you think?
I've not seen it. And I know David Unwin hasn't seen it either. I think he may have had a couple of these lean mass hyper-responders, but I haven't seen that yet. And I'm quite careful about monitoring my patients' cholesterol. So I've seen improvements in lipid profiles. Obviously, I'm really interested in HDL and triglycerides because they seem to be sort of better indicators of metabolic health. But obviously, I'm keeping an eye on the LDLs as well. And the LDLs, they move a little bit up or down or stay the same. But I haven't seen anybody's LDLs, go rocketing sky high. So and there's some decent evidence coming through, isn't there, that actually your LDL, even if it does go up, isn't the most important thing. Your markers of insulin sensitivity are actually much more important in terms of your long-term health. Having said that, obviously I'll have to have that conversation with a patient if I do get one that suddenly has a high LDL. What do they want to do about it? Do they want to adjust their diet? Do they want to try a statin? There's all these difficult conversations to have, isn't it? But it's a patient-centered approach, isn't it? And you need to try and sort of work out with the patient what works best for them, giving them the best available information that you have at the time.
Do you routinely do, or do we, that's part of the NHS, do we routinely test for insulin sensitivity or fasting insulin? We don't, do we?
No, that's right. You can't get it in primary care at all. I think in the hospital setting, you can get it, but only in, very sort of specific situations. I think if you suspect that somebody's got an insulinoma or something like that. So we can't get insulin tests. I mean, you can try your best to, to sort of guess it by looking at their triglycerides and the HDL. Obviously the HbA1c, although that's not a brilliant marker either. But we've stopped doing oral glucose tolerance tests as well, which are probably a better test of sort of insulin sensitivity. But we can't test it.
I wonder why we don't have these as part of routine care. Are they more expensive tests to run? Is that why? Or
I think it's partly might be a financial thing, but I think it's to do with the stability of insulin as well. And transporting from the lab. So where my surgery is, is an hour from the local lab. So I'm not sure it's stable with transport. We do this urine C-peptide test. Again, it's not widely available, but we are able to use that. And that's quite useful if we're trying to sort of work out whether somebody who's been labeled as a type 2 diabetic and they've been on insulin for years, and we're thinking about trying to, de-prescribe their insulin. So it's quite useful to do a urine C-peptide to try and work out whether they're actually still producing any endogenous insulin, or whether they're actually either burnt out type 2 or actually they're, a type 1 that's been misdiagnosed.
How many of your type 2 diabetic patients end up on insulin if they don't introduce dietary changes?
Yeah, it's a good question. We don't put people on insulin anymore.
Interesting.
We just don't do that anymore. And I'm on a mission to, those of them that are on it, that are keen to try, I'm really keen to get them off, because there's some reasonably good evidence, I think, isn't there, that actually if you put an insulin resistant person on insulin, then you're really not doing themselves any favors in terms of their long-term risks of cardiovascular disease and cancers and things like that. So I think that's a mistake, putting somebody, a type 2 person, on insulin.
So you encourage your patients, obviously, to adopt the low carbohydrate lifestyle. So you must also find yourself in situations where you're actually de-prescribing. How do you go about it? Because I know that I've heard it before that in medical school, you do not learn about de-prescribing. You learn about how to prescribe, but not de-prescribe. So how do you go about it? It must be tough thing to do.
Well, luckily, there's a really good paper about it. So Campbell Murdoch and David Unwin and David Cavan, I think, produced this paper that was in the the Journal of British General Practice, or I can't remember what it's called. Anyway, it's a really good paper. I use it all the time, and I send it off to colleagues. I send it off to patients sometimes as well, because there's some really good advice in there about what to do if a patient's on, insulin or glyphosate particularly, or the SGLT2 inhibitors. So I'm much more sort of comfortable with the de-prescribing now. And also we had, again, back to those webinars that I've been running, we had Campbell Murdoch came and did a brilliant talk for us back in, I think it was February time. And that was there were lots of GPs and practice nurses there and a few dietitians. And it was great to hear Campbell going through using a case study about, how would you de-prescribe for somebody who was, already on a load of medication. So patients are often really keen to, come off medication, aren't they? Because they've ended up on them and it wasn't really what they had in mind. I mean, very occasionally you meet a patient who's quite happy to be on drugs because they don't want to change their lifestyle, but I'd say they're rare. Most people are quite keen to avoid being medicated.
So what are some of the medications that you find yourself de-prescribing? I'm sure one of them would be blood pressure medication. Is that?
Yes.
Do you see that?
Yes, absolutely. So I'm really keen to get people off benjoflurazide. It's a terrible drug. I mean, it's a drug that some people really need to be on if they haven't been able to tolerate some of the other blood pressure medications. But actually, benjoflurazide can put your blood sugar up, so it makes no sense. First one, I'll try and take them off. Obviously glyclazide as well. I think glyclazide is a terrible drug, because again, that can actually make people more hungry. So I'm not a big fan of glyclazide. Having said that, I should say this podcast obviously isn't medical advice, is it? So I wouldn't want anybody to stop their glycozide based on what they hear today. You know, it's obviously something they need to discuss with their own GP. But I personally try and get my patients off glycozide if I can, because it's not a great drug for various reasons. But yeah, blood pressure tablets, you're right. Often we do prescribe painkillers too, and that's because, you know, as people shed a stone or 2 stone or 3 stone, often their knee pain goes away. Hip pain too, general arthritis pains can go away, fibromyalgia pains can go away. The proton pump inhibitors that we use for acid reflux, so I quite like stopping those too.
Omeprazole is a common one.
Exactly, omeprazole and lansoprazole. So so often as people lose weight and they become more insulin sensitive, they don't need their proton pump inhibitors anymore, which has got to be a good thing, because actually they can really affect the way that people absorb their micronutrients. So that feels like a real win as well, getting people off those. My favorite de-prescribing thing though was a patient who I'd managed to get off his sleep apnea machine.
Amazing.
That was the best one. But
so what went on there then? How does low carb help a person with sleep apnea?
So that's basically losing some of the fatty deposits in his head and neck area, particularly the tongue, but also, you know, the jowls.
Yes.
So he lost a good couple of stone, this chap, and it was lovely actually. I was processing my letters and medication requests and blood tests and things one Friday evening, I think, still at work quite late. And it was, you know, nobody wants to be at work late on a Friday night, but I had this real sort of lovely feeling when I had several sort of letters and results that came back that were really sort of showing me how well this approach was working. And one of them was this lovely chap who he'd been to see the respiratory team, and his consultant said, Mr. So-and-so has decided he doesn't need his sleep apnea machine anymore, because since he's lost weight, he's sleeping and breathing normally. So fantastic. And the other good thing about him is that, you know, we've prescribed lots of medication for him and his wife as well. So his wife struggled with her blood pressure a lot. And since the two of them have done it together, you know, we've got her off her blood pressure tablets.
You must find that when someone in the family starts adopting the low carbohydrate lifestyle, others follow. That you do notice that, right?
Oh, absolutely. Yeah. It's this lovely sort of ripple effect that you can't measure it. So even though I know that I've got lots of patients who shed several stone and got rid of their pre-diabetes or their diabetes and the blood pressure problems, I know that it's also having a positive impact on their work colleagues. You know, I'm always hearing these stories of, oh yeah, the girls at work have decided they're impressed by what I'm doing and they're doing it too. So yeah, no, it's absolutely lovely seeing how this, you know, this positive this change in lifestyle that actually makes a difference and people enjoy, you know, is definitely sort of propagating.
That's actually amazing, because that's exactly what happened in my own family as well. It just took me, the type 1 diabetic, to actually do it first, and I had a good reason to try and experiment with this, but everyone else followed.
Yeah. No, that's so powerful, isn't it? Seeing somebody you know and respect or love, it, you know, seeing them getting a hold of their, you know, sort of like, you know, their sort of health trajectory, you know, witnessing that is really powerful, and actually it gives people hope as well, doesn't it? They can, you know, they can see actually if Nairi can do it and you've got more challenges to your body than they had to theirs, then they absolutely can do it. So I think that's fantastic. You're a beacon. You're a beacon of hope.
Thank you so much. You've been an inspiration to me. You've been so supportive to me online, and you know, thank you so much. Actually, it's interesting because people are now adopting the low carbohydrate lifestyle even when they don't have type 2 diabetes or blood pressure problems. So they're using it as a preventative sort of lifestyle, so a method rather, to avoid developing insulin resistance. And so that's amazing, right? I mean, you do something now so you don't end up with type 2 diabetes. And that's amazing to see. That is just so powerful. It's inspiring for me as well.
Yeah, it makes so much sense, doesn't it? I mean, and I never had diabetes or pre-diabetes, but I decided to go down that road myself just because I could see that other professionals were doing it, and I was like, what am I missing out on? And actually, I feel so much better on it as well. You don't get that sort of slump after your carby lunch, and you feel a bit more switched on, and you're not a slave to your hunger anymore. And I had a really busy day yesterday, and I managed to skip through breakfast and lunch without being even hungry at all, and it was brilliant because I wasn't sort of reaching for the biscuit tin in the way that I would have been previously, and that's got to be good for long-term health, isn't it? Not having those highs and lows all the time. But also, it's not just about, you know, everyone's got their own goals, haven't they? It's not just about preventing type 2 diabetes, but it's also about reducing your risk of dementia, isn't it? And a number of cancers and various other issues as well. So yeah, there's lots of reasons to get your blood sugars stable, I think. And then the COVID pandemic too. I mean, that's been very obviously something that's been more sort of hard hitting for people who, you know, for whatever reason have, you know, unhealthy metabolism. So yeah, that was one of my motivating factors actually at the beginning of the pandemic. I thought, gosh, I need to tighten up my diet because I'm going to meet COVID at some point. I want to have really good stable blood sugars when that happens.
I think you have a pinned tweet on Twitter about specifically COVID and the importance of good metabolic health. Tell us a little bit more about it, please.
Yeah, so I remember reading something quite early on. Well, it was very obvious, wasn't it? All those photographs that you saw in the papers, all the people who'd become ill were people who were tragically, you know, metabolically unhealthy. Either, you know, they were overweight or they had type 2 diabetes or high blood pressure. And it was so obvious so early on. And then I read this interesting paper about how one of the theories behind why COVID was so devastating for people in that situation was to do with the way that the virus was sort of hiding from the body's immune system by sort of covering itself in the sugar that was available to them in the blood. And I'm not quite sure where that theory has got to, but that made so much sense to me. And so it makes so much sense that actually, if you've got blood sugars that are very high or changing a lot up and down, then that potentially could lead to a really sort of a very welcoming environment for the coronavirus to, you know, to thrive. Yeah, so it just it drives me nuts that we haven't managed to get that message across more sort of vociferously, I suppose, across the whole world, that actually there is something you can do to improve your metabolic health. And actually, if you do improve your metabolic health, then you might do much better when you meet COVID. So yeah, so that's why I pinned that tweet, and I just, you know, I'm telling everyone that will listen. It feels quite important. And I had, I think about the time when I did that tweet, actually, I'd been doing a flu clinic. Just, it wasn't the COVID vaccinations, it was just the normal seasonal flu clinic that we were doing at the surgery over one weekend. And I remember seeing a couple of my patients that had done so well. And it was all because, you know, we told them at some point, you know, cut your carbs and you'll improve your lifestyle. It was one of those really brief interventions that they just clicked and gone with. And these three guys, there's a brother and a sister, and then the husband of the sister, and the three of them had, between them, they'd lost several stone. One of them's lost 6 stone just himself, and got rid of his type 2 diabetes, and they were all massively improved their health. And I saw these guys in the flu clinic, and I was like, wow, what have you done? And they just listened to what somebody had said about cutting the carbs and feeling so much better for it.
That's a message I think we need to hear more of.
Yeah.
In fact, we haven't heard that message at all. We haven't heard about the connection between immunity, strong natural immunity, and the ability to fight any infection.
Yeah.
Including COVID, of course. Yeah, we need to get that message out.
Absolutely. Yeah. It's absolutely incredible, isn't it, that we haven't got that out. I mean, do you remember Boris Johnson did this weird little selfie video? I think he was walking around Downing Street or something, saying, I've lost a bit of weight, I've been out running, and I've cut my carbs. And that was the only time we ever heard anything about sort of
about carbs.
He mentioned carbs, yeah.
And I know Asim Malhotra is working tirelessly to change sort of dietary guidelines, but that's a tough battle. It is a tough battle.
Yeah, really tough battle. Yeah, you worry. I really worry about the, you know, why is it taking so long to change? You know, it just, if you look at the Public Health England's Eat Well plate that's being promoted, you know, in doctor surgeries and schools, it's just nuts. It's absolutely crazy. I just can't get my head around how that approach is going to work for anybody, really. Yeah, so they need to change, and there's lots of, you know, worrying potential reasons why they haven't changed yet, but I'm hopeful that at some point they'll have to stop resisting it and just get on and change their approach.
I remember at the diabetes clinic at the hospital, there was a big poster on the wall with pictures of complex carbs, lentils, chickpeas, and of course wheat.
Yes.
So it was all there, and it said something to the effect of a perfect diet for diabetics is a balanced diet or a high fiber, or something to that effect. And I followed that diet, and I did very badly on that diet. And they gave me an insulin pump, and they said, now you will see some improvement in your blood sugars or in your HbA1c. And I didn't. The pump did not help me at all. It made life easier. It didn't help me. What did help me, though, is where my discovery of the low carbohydrate sort of way of eating, and of course the CGM. Now that's my next question for you. Yes. CGMs are amazing. I mean, I use the Freestyle Libre. I'm interested in a few other brands as well, but I've been using this Freestyle Libre for 4 years now, non-stop, of course, and the data and the information it gives me is amazing. Do you have any of your patients? Of course, it's not prescribed for type 2 diabetics, but does any of them self-fund it just to improve their health?
Yeah, absolutely. So I've got a guy who comes along to I run these groups at the surgery once a month, and he comes along to that, and he's on insulin, and he's a really smart, switched on guy, and so he's managed to self-source it. He wouldn't get it on prescription, but it's making a big difference to him. It's a game changer, actually. And I was at this diabetes conference a month ago, and they were talking about this artificial pancreas, which is coming through, where they link up the CGM with the pump, and that's going to be a game changer, I think, isn't it? because it's that cheesy expression, knowledge is power. But once you see the effects that what you're consuming on your blood sugar, you just can't unsee it, can you? So, you know, you eat your nice healthy grains and your blood sugar goes rocketing up to, you know, 14 or whatever. And you're like, oh, maybe I should stick to the, you know, the salmon and the eggs and the
exactly.
So Abbott have been doing this 2-week free trial, haven't they, for the Freestyle Libre? So I've been encouraging my patients to, you know, any of them with type 2 diabetes or even pre-diabetes, I don't think they check, you can you know, get one of those, and even if you only have it for 2 weeks, that can sometimes just be enough, can't it, just to make you realize the effects that those foods are having on your blood sugar.
Yes, and that's the advantage of not being diabetic, so you can just self-fund it. For 15 days, just buy yourself one sensor. The app is free to download on your phone. Yeah. And the data you'll collect from it is invaluable. But for me, being type 1, obviously I have to match it. I still have to match my insulin to my food intake. So I need regular, such continuous data. But so it's interesting that people are actually self-funding and buying it.
Yeah, absolutely. And I think for women with gestational diabetes, I think it would be so useful for them as well. Because often they're, you know, they're, again, a bit like the patients with type 1 I was saying earlier, they, you know, they get whipped off to the hospital, and so we lose contact with them. We often don't see them. I've got several ladies who the first you know that she's pregnant is you get a letter from the hospital clinic saying, so she's got gestational diabetes, could you please start her on metformin and then insulin? And you're like, oh, I wish I'd had an opportunity to have a chat with this lady and see if we could just sort of, you know, educate her to, you know, to cut back on her carbs and see if how that works. Yeah, it's a bit of a, so once they've got their CGMs, and you know, I'd really encourage them to self-fund if they, you know, or get the 2-week free trial. You know, it just could make so much difference, couldn't it, in terms of the, you know, the knowledge.
Yes, fasting. How do any of your patients choose? It's something you have to choose to do, right? Fasting, intermittent fasting or longer fast, but it's something that can't be forced upon you. So do any of your patients choose or to do fasting or intermittent fasting, say not eating 14 hours, 16 hours, which isn't that challenging, but
yeah, it's not something I've really got in. I haven't really got into it so far. I mean, I do encourage people. I'm really convinced that not eating for 2 to 3 hours before you go to bed is a good thing for lots of reasons, because your body is much better able to, you know, to digest, and you know, if you're not constantly feeding it, and bedtime, you'll sleep so much better if you're not digesting. So there's already good reasons for that. And so I often say, you know, don't eat for 3 hours before you go to bed, or 2, and then in the morning push your breakfast back as late as you can. And obviously you have to sort of modify that advice depending on what medication they're on. But yeah, and I do tend to recommend sort of a time restricted eating sort of pattern, and that window is adjusted according to, you know, preference and whether they're on medication and things like that. But I've always given them the message of avoid snacking, and actually people who are on a low carb diet often don't need to snack anyway. So I have had a few people that haven't done very well on their low carb diet initially because they've heard that nuts and cheese are fine, and so they eat lots of them. So you know, encouraging not to overeat on nuts and cheese, and also not to snack, because you want your insulin levels to be being, you know, sort of up and down rather than, you know, sort of constantly on the go, don't you? But no, I did have one patient who he was attempting an extended day fast, and I think he was on, and I hadn't encouraged him to do this. He'd completely done this on his own. I have no idea where he came up with the idea. But I got this message saying, what would you recommend? I'm on day 4 of my fast. And I was like, oh my God, I have no idea. So yeah, and I don't know about you because you do quite a lot of fasting, don't you? I don't know how far you take yours.
Every 3 months or so. So I recently did a 90-hour fast. I wrote a blog about it. But now, just a few days ago, I ended a 100-hour fast. I broke my own records, and I'm writing up a blog about it. I will put it on Twitter, of course, and on the website. I don't do for the sake of it. I don't do to lose weight because I don't have any excess weight to lose. But I do it to regain insulin sensitivity. And I'm writing all about it. That is my primary goal. When I notice that, for whatever reason, even though I do eat low carbohydrates, the meals, but I do notice my insulin intake is rising consistently. It just gives me, I think, it just tells me that, hey, you're not responding to insulin the way you should. So do something about it. The only way I find that I can reverse that is by doing longer fast, 3 days. 3 days usually does it for me. So, but I did attempt just to break my own record and see what happens and write up the details about it. I lasted 100 hours. It was perfect. So,
wow, gosh, I can imagine your clinic would not know what to do with that information.
No, I don't think they will. I won't. I mean, they will see when I have an appointment with them. Obviously, they will see that I haven't eaten. Obviously, because I haven't been giving myself any insulin injections. Yeah. But my blood sugars were perfect on 4 units of insulin per day. Wow. And that is just amazing, because when I started eating again, I found that all I need to cover my foods was just tiny amount of insulin. Now that is insulin sensitivity. I have become, by not eating for a couple of days or 3, I mean, no one needs to do 100 hours, but even sort of the 36-hour fast, which really isn't that difficult, helps me regain insulin sensitivity. So that's why I do it. That's my primary goal. I don't like being too dependent on insulin and then needing more and more insulin.
Absolutely. That's really interesting. So did you say you take 4 units of your long-acting insulin?
That's all I need. Well, but I'm on a pump, so I only
right. You're on a pump.
I only take NovoRapid, which is quick acting. But 4 units of insulin is spread over the 24 hours. So something like 0.20 or 0.15 sort of units per hour or per 2 hours or something. So to add up to the 4 units. And my blood sugars were consistent, so straight line, quite low, but fairly stable. So, and I didn't need many glucose tablets to treat dangerous hypos. It was amazing, but I do it primarily to regain insulin sensitivity. So that's why I do fasting.
Yeah, no, I'm really interested in that, because I don't know anything about sort of long fasts, particularly in patients with type 1. I mean, the idea is quite terrifying to me, but you sound like you know what you're doing and it's going well for you. So that's absolutely brilliant. And then, of course, Ian Lake did that 5-day fasted run, didn't he? That was really, really interesting.
I interviewed Ian Lake and we did talk about that. So that was interesting. And you see that people survive, even lean people, and I am lean. We have enough fat to burn. There are calories if you want to speak of calories, but yeah, we have enough to burn for 5 days, longer. Yeah. So Dr. Tapsell, how can people reach you if they want to follow you on Twitter? And you have to follow Dr. Tapsell on Twitter. I recommend you to follow Dr. Tapsell. She posts the most amazing articles and threads. So how do people find you on Twitter? Because you are mostly active on Twitter. I haven't found you on Facebook, but
yeah, no, I don't do so much on Twitter. I've kind of sort of kept my head down lately because I'm finding it all a little bit hostile at the moment, and I'm too busy for it anyway. And I think my handle is @RuthTapsell. That's it.
I'll put it in the description below. And before we wrap up and before we say goodbye to you, why don't you tell us about some of the work you're doing to train other GPs across the UK and introduce them to the low carbohydrate lifestyle? Because I think that's something you're actively promoting, and you're very, very active in, promoting. You used to send me the links. Please share this with, your consultant. And you're also involving diabetes specialists, right? The diabetes consultants in these training courses. Tell us more about that, please.
Yeah, so I guess sometime during the pandemic, and I was sort of banging the drum loudly in my area and realizing I wasn't really getting very far, and so I thought I needed to reach out to other GPs and practice nurses and dietitians who perhaps might be interested in doing the low carb approach but maybe didn't just know about it. And to also give them the confidence to be able to actually get going with it, because I've been running these webinars with Gail Gerry, who's this practice nurse in Solihull. And Gail was saying she'd run a course with Dr. David Cavan, and she'd had a message from somebody who attended the course saying, that's amazing, but I can't imagine where I'd start. How do I get going with this? And so they really didn't have any confidence. So Gail and I decided to start running a series of webinars once a month. Well, actually, at one point we were running them twice a month. And the idea was that we'd have a different speaker each month, but we'd also have people would come with and have the opportunity to, ask questions and just sort of build their confidence. But also what was quite powerful was that seeing lots of other people in the Zoom room. So, sometimes we would have over 100 participants in these webinars. And I think that's really empowering when you can see that actually this is something that's really sort of catching fire. It's lots of momentum behind it, and there's obviously safety in numbers. So if you can see other people who you respect in the room who are actually doing this and getting great results from it, that can really be very empowering for that individual. So we've been running these webinars ever since January, and we've had some absolutely fantastic speakers along. I mentioned the renal physician. We've had a pediatric endocrinologist who's helped, I think 1,000 children to, lose a huge amount of weight and reverse all their fatty liver disease. And, some of them have had type 2 diabetes that they've managed to improve, and their lipid profiles. We've had a cardiologist. We've had Dr. David Cavan along. We've had Jen Unwin, David Unwin. We've had so many. It's been absolutely brilliant. And so that's been lovely, because we've had so many GPs who we've connected with through these webinars. So we've kind of been advertising on Twitter and various other, GP Facebook groups and things like that. And the movement's really grown. And what's really lovely is every so often I'll get an email from somebody who I don't know, but has attended one of my webinars, saying, I just needed to share this with you. I've had this patient who's, got rid of their type 2 diabetes and got rid of their fatty liver disease, and they're chuffed to bits and wishing they'd sorted this out sooner. And so that's been really, really powerful. It's been crazily busy. I haven't had time to do it, but I've squeezed it in, and it's been really rewarding.
And you've been single-handed. You started it single-handedly, so that takes
sort of. I came up with the idea because I'm a PHC ambassador as well. So the Public Health Collaboration, this fantastic charity. So I was at one of their sort of ambassadors sort of conferences. It was an online thing because it was during the pandemic, and the ambassadors are amazing. They've got really, they've got so much energy, and a lot of them are expert patients who've sorted their own lives out and are wanting to share it, and they're really trying to reach out to local professionals, GPs and nurses and stuff, but struggling to. So I kind of, during that session, I kind of came up with this idea that if I could run these webinars, then the ambassadors would be able to invite their local GPs and practice nurses to come along and actually see that this is a real thing. This is really effective. And actually, if they're not doing it, then perhaps they should start thinking about it. And then they'll start seeing these impressive outcomes with their patients. And it's grown, and it's really grown. And it was intended to be for primary care people, but actually we've had lots of specialists come. So we've had some endocrinologists come, and some pediatricians, and all sorts. It's been absolutely brilliant. So, and I get lots of emails back from people saying, "Wow, that was amazing. Sign me up for your next one."
It's certainly grown, and I've noticed it because I recently found out that my GP's clinic as well is well familiar. They've attended your webinars, and they're familiar with the low carbohydrate sort of lifestyle, and that's not all. But I also found that my current consultant, diabetes consultant, is also familiar with the keto diet. So he's not anti keto, so to speak. So he's very encouraging and supportive. He does tell me though, look, I can't support you. I don't know much about this, but you're doing so well. Just continue to do what you're doing.
Brilliant.
Sometimes
that's brilliant.
That's all you need to hear.
Yeah, that's it. So that was my main thing, is just don't dismiss it. So if a patient comes to you and says, I'm doing this, don't discourage them. This is actually, and I hadn't heard of keto until a few years ago and didn't know what to say to the patient, a bit like I don't know what to say to someone when they tell me they're doing a long fast. But actually, yeah, so if the only thing I achieve from these webinars is that some specialist in some hospital setting in London or Birmingham or wherever doesn't dismiss it when their patient says that they're following a ketogenic diet or a low carb diet, then that's a good outcome. I just don't want people to say, no, don't do that. And then they'll go back to eating their low fat, high carb way of eating, which will potentially wreck their diabetes control.
Well, and I don't think we realize that. We don't realize the damages, or we think that we're sort of invincible and it's not going to happen to us. I've had type 1 for 43 years. I'm kind of almost expected to be nearly blind now, and with the sort of kidneys not functioning well, but I don't have any of those complications.
Yeah, no, that's fantastic, isn't it? So we had this patient, really sadly, who came to us too late. He'd been at another surgery, and by the time he'd come to us, he was in his late 40s, and he'd had every complication under the sun. And I just found that so sad. And and there are so many people like that, aren't there, who've done the damage because they've been, doing their best. It's not that they haven't been trying, but they've been using tools that don't work. And it's just, I just find that so sad and so utterly, preventable, really. But I really, really hope that, the word is spreading. I was really disappointed this conference I went to last month that the most senior diabetes specialists there seemed to be quite anti-lifestyle and pro-drugs. And I sort of came away really sort of very disappointed by that approach, really. So I'm hoping in a few years to come, that attitude will have changed.
I hope so too. Well, I thoroughly enjoyed our discussion today. Thank you so much for coming on our channel and for making time for us. I know you're busy. You only just made it today, didn't you? You had to rush back from London.
Yeah. No, it was lovely seeing you. Thanks so much for having me on.
Thank you very much. Hopefully we can have a chat again soon.
Yeah, that'd be lovely.
Thank you.
Take care. All the best.
Thank you.